Let me see now. It's back to oh my God. They need to fill that out. Some of them have said they already did it, and I said, respond to email and send she was there. So like, I'm thinking, okay. She sent 2 different emails about that. And the other is it on? You have to click on it and then it says that be what the selection is. And then also mention
See, my kid was sleeping 7, I'm like, it does not work.
Does not happen. She wakes up
yeah, we are going to
I'll talk to the monitor. I said, it is still dark, go back to sleep. Yes, ma'am.
I'm not even back in the crib.
She used to. When she got the phone, she used to.
No, you're good. You're good. You're okay. Thank you.
I can't like do it. I get like 45 minutes in and I'm like, he's still in there crying. I gotta go. I feel so terrible. Like I just feel so terrible.
Okay, we can get started back again. So a little bit on some complications, and then we're going to get into some diagnosis and treatment, and wrap it up for grad services. Okay, so list here, status epilepticus is the #1 big complication that we're concerned with when it comes to seizures. Okay, and then there's sudden unexpected death from epilepsy, SUDEP. So those are more urgent, life-threatening. Of course, there's quality of life issues, and we've already kind of talked about some of those. So you can start thinking about some of the things that we'd be concerned about there. There's still a social stigma out there with seizures too, a little misunderstanding. Like I was saying, generally, like it's the tonic-clonic that the general public tends to think seizures are. So if somebody has to communicate that they have the seizure disorder, that's usually what the layperson's expecting. So having a lack of understanding of even some of those absence type or absence type seizures, that doesn't help. So hence all these people making these YouTube or TikTok type videos to spread awareness, which I think that's the good side of the internet, right? When sharing that awareness and hoping to decrease the social stigma. Right? Some people are wearing, of course, the medical alert bracelets are a must for these folks. And then some have like on their hat they have seizure. I've seen some videos where people have like these little signs because they may just have those staring absent seizures, and they want others to know that they see that sign on their hat that says they have seizures. So it kind of lets people know who maybe aren't aware that, well, maybe that's what their seizures look like. So decreasing social stigmas, or having a social stigma is a complication. It gets in the way of work, school, all kinds of aspects of life. Depression is something that's a concern and a complication. One, because it can be an emotion that's triggered from a seizure in that postictal stage too, or leading into in the prodromal stage of seizures. But also depression in the fact that their quality of life and the social stigma and all these other things are playing into it. Of course, that discrimination is definitely out there. Driving sanctions. So we mentioned it, or I think it was Hillary was mentioning driving sanctions. And in Oklahoma, I think they have to be seizure-free for 6 months, so they're controlled on medications and seizure-free for 6 months before they're allowed to drive, so they can drive. The exception would be is if it's well documented that their seizures are nighttime only type seizures, so only happen during the sleep state. So hopefully they're not sleeping while they're driving, because that's a little bit more of a concern than the seizure during the sleep. So there are driving sanctions. It depends on which state, and that's just where Oklahoma sits with that. So there's not a whole lot of rules there. Again, they just have to show that they've been seizure free, so it doesn't happen while they're driving. And then, of course, side effects. There's lots of side effects with all kinds of medications, but you can have some extra ones here with seizures. seizure medications. So first, I want to talk about emergency, all right? Status epilepticus. So, I don't know if you've been around anybody with a seizure or somebody who's had seizure disorders before, but people without a complete understanding about seizures feel like every seizure every time is an emergency. And it's not necessarily true. I mean, I've taken care, the kid I was talking about who does the tonic type seizures, that lasts just a few seconds, he's actually in a constant seizure state. So that's just that breakthrough seizure on top of his basal seizure state. So sometimes we have some severe cerebral palsy, kids with cerebral palsy or other birth injuries that are in a constant seizure state, nonverbal, pretty much total care type kids. Really sad case, but you know, there's work with pulling out of seizures and seizure medication so that there can be some kind of quality of life in there. But it wasn't an emergency because it's all the time. So it has the permanent brain damage and has the constant seizure state. So that does exist, and all that just to say that not every time it's an emergency. How do you know when it's an emergency? Is when you have any seizure lasting greater than 5 minutes. So that's why it's so important. Our job, don't forget to check the clock, right? So if you have that patient where the family member pressed the call light, they have a report. They knew they were on seizure precautions. They knew this patient is there for seizures. They have the EEG monitoring and the video, so we know. So I might look at the clock when that call light goes off, right? As I'm running into that, well, carefully walking fast into the room, right? Because we don't want to run in the hospital unless there's a code. Even still, because you could trip and fall, and then who's going to go to the code, right? Walk fast. But I'm checking that my clock when that call light goes off and verifying that they're in that seizure state. I mean, we didn't witness the onset of that, but you can kind of estimate that's about when it started. Family member called us into the room at that time. Or if you're in the room and you see a tonic state, which is usually the initial stage of the tonic-clonic version, right then and there. As soon as that symptom starts, that's secondhand, start your timer and stay with the patient, make sure that they're safe until they move through it. Now, if that seizure is lasting longer than 5 minutes, that's a long time when you're sitting there with somebody watching them go through a struggle, right? That they're usually not aware about, because this usually happens in your generalized type seizure, if they're going to go into epilepticus. It can happen in any type of seizure, don't get me wrong there, I'm just saying generally that's the type that happens, so you have all that muscle movement, and imagine the fatigue for 5 minutes of this excruciating misfiring in their brain for so long. The other piece to this is could be consecutive seizures. So even if they didn't last 5 minutes, there wasn't a recovery of consciousness in between before they then went into another one. This is what we call status epilepticus. Alright, so it is an emergency. This is when you're going to pull the code and get all the friends in the room so they can bring the cart and get all the rescue meds that we might need, because you've got all of them in the cart, right? Valium, you've got Ativan, you've got all kinds of stuff in it. Okay, so if somebody's in status epilepticus, and maybe it's the tonic-clonic type, and they've got muscle tension, they're not breathing, right? Apnea, potentially. Risk for airway occlusion, so hypoxia, no airway. The saliva, there could be aspiration going on, right? And obviously if you go anoxic for too long, there could be brain death that occurs, okay? And then they're in a coma state, we might have them intubated, but then we realize their brain stem's not functioning, and this is a seizure that put them into this sudden unexpected death from epilepsy, or the SUDEP. So that's why it's an emergency, because it could result where we're going without oxygen to the brain for too long. So our priority in this case is usually going to be that rescue med as far as like interventions go, but before we protect that safety piece. So airway, breathing, circulation, medication, okay? Again, it can be any type of seizure, so it might look different depending on the type of seizure that they have. Okay, and then there's these different variations, convulsive and non-convulsive. So this is where I'm talking about, it can be any type of seizure, but you've got your convulsive type, prolonged or repeated tonic-clonic. Most common variation, like I was saying about for status epilepticus, is that convulsive tonic-clonic type. And then you have your non-convulsive, where it could be repeated or prolonged focal impaired awareness. So the lady in the video had the focal awareness, but if hers was a focal impaired awareness and it was lasting really a long time, it's hard to know until she comes out of it if she was aware. But it's the length of time or frequent coming out and going right back in without a regaining consciousness in between. Okay, so those pieces are still there. Longer than 5 minutes, no regaining of consciousness in between repeated seizures. Obviously, hypoxemia, respiratory failure, dysrhythmias, hyperthermia. You know, all those muscles are being excited. They get hot. Using all that energy causes hyperthermia. And systemic acidosis from extra lactic acid from those muscles being released, so they can go into a metabolic state too. Okay? So the rescue meds when it comes to status epilepticus, like I said, your PAMs and your LAMs, lorazepam, diazepam, and midazolam. Lamapam, damn. Rapid acting benzodiazepines. So they act fast, so that's why we want them, right? Usually on the top cart of your drug, your drug drawer on your code cart. So that's why you want your friends to come in and call that code so everybody can bring those meds, and you can get a provider in the room, and we can go ahead and start supporting the patient's respiratory status and get these rescue meds on board. So I put a couple other pictures in here. Top right corner is rectal diazepam, right, which is a gel, a rectal gel. These are outpatient medications. So my friend who was in middle school had this medication, and if he was going into a status epilepticus in the middle of the hallway, down the drawers go and in the rectal Valium, which comes with that. If he knows in the aftermath that we had to do that in public, which has happened to him but not at school, thank God, there's that piece that goes along with that in the aftermath. I just want to say that, because that's the way it's been in the outpatient, because you know how you walk around with an IV, right, in the outpatient setting, so they have this rectal Valium that a lot of people were carrying in their pack for their emergencies, if they're not pulling out of that seizure, right? Well, now we have nasal Valium, much nicer for out in public, right? Goes into the capillary beds up there in the sinuses, quick absorption, there you go. That's what my friend carries around now. He's got a few other things too, we'll talk about that. This is when I wish I could bring my friends with me to school and let them talk to you about their experiences. So I had the diabetes kid, and then I got my Jonathan, who's seizure epilepsy. So those are your medications for rescue because they're fast-acting benzodiazepines. But they're likely going to give them some of these longer-acting drugs, the phenytoin, dilantin, fosphenytoin, or phenobarbital. Talk about meds, they're going to come up in a little bit here. Those are your other rescue medications. Pretty good so far? PAMs and the LAMs. And just another slide, just kind of to conceptualize some of what's going on here during your status epilepticus. Okay, continuous seizure, just another way to kind of organize your thoughts. Severe injury and death can result, increased suicide risk, sudden unexpected death in epilepsy. So all the factors, all the things that are going on at the same time. Some considerations for elderly, right? Some may have a first single seizure and then never have another, right? So the environment was set up, they've already got maybe some demyelination and maybe some kind of neuro disorder going on, so the perfect storm was there, but then they recover from whatever underlying provoked piece of that seizure caused it, perhaps. But it must be recurring for anti-seizure drug therapy. So, if they had one seizure event, we're going to monitor and find out if we can figure out if there was an underlying cause, perhaps fix that, and then that's why they never have one again. Or then we realize, okay, now we've got some degeneration of nerves, and now we've got some unprovoked seizures occurring, aka seizure disorder, and we'll start them on medication. With the way that they metabolize or don't metabolize medications, these are things we need to consider with seizure meds, anti-seizure medication. And they're more likely to have lower seizure doses. So their kidneys or their liver may not function as well, so you could have more toxic levels. So they require a little bit lower doses, perhaps. So knowing their history, and this is, obviously for the provider to decide what the strength of their medication is, but these are things we can be alert of as nurses, so we know how to advocate for what their needs are, right? And make the provider alert to perhaps something in their history. Okay? All right, diagnostics. So a little EEG in the background. So anytime we're going to try to diagnose, and of course we're not diagnosing a seizure disorder, that is for a provider, not for a nurse, but we need to know how it's done so that we can make sure this is happening for our patients. So it begins with accurate and comprehensive health history, which we can help provide, right? We can be alert to things, we can watch for things, ask the right questions, share that information with providers, and a detailed description of their seizures. So if you're working in the ER, usually the nurse is going to see and assess the patient before a provider might come in and evaluate them. So that's where our good health history is going to come in, and knowing to ask certain questions that might point us in this direction, especially if they have a history, or they've got a bracelet on, and you want to ask them about their seizures. And maybe, is this a change from what they're used to? Hence the reason for showing up, right? Or somebody else brought them, perhaps. So good health history. Initially though, if this is a new onset for somebody and they've never had a seizure before, or they're going to go through some of this scanning, we want to make sure there's not a lesion in their brain or something that they can see on imaging, right? Rule out any structural issues or masses. And that'll tell us if, hey, is this something we can operate on, perhaps? Depends on where it is and if it's operable or inoperable. Sometimes there's arteriovenous malformations, a little clustering of arteries and veins that they can go in and surgically repair. And then the hydrocephalus piece, or extra water in the brain, shunting can kind of relieve the pressure off, and that may resolve some of those seizures, right? Provoked type seizures. Not necessarily status, or not epilepsy, for example, or seizure disorder. So those are causes for seizures where we could eliminate the underlying cause, right? Provoked type seizures. Now let's just picture some imaging, right? And how the image can be improved depending on the method we're using to capture those images. And then there's some nuclear imaging that exists out there, the single photon emission, computerized tomography, right? 3D pictures. Kind of helps hone in on a little bit more on maybe what type of underlying issue they have going on that's causing their seizures. It's nice that medicine is advanced this way. Nuclear medicine's really cool, really complex. So if we've ruled out structural issues or any kind of surgical interventions that might be needed, then we want to investigate potentially with EEG, right? So that's all the electrodes that go on the different portion of the brain that help them pinpoint where there's electrical misfiring. So just like we put leads on your chest to look at the electrical conduction in the heart, we do the same for an EEG. Very complex, tech position, they go to school for it, figure out how to read one of these things. I always like to go in the room and kind of sit with the tech and be like, what do you see? Because I don't always see what they see. Like, that was a seizure? Are you sure? This is an example of one here. So in the right hemisphere, they were able to identify the activity in the brain in comparison to what else was going on and what was prior. And so this is considered seizure activity. So it's the primary tool for diagnosing seizures, because we can get in there and see, is it partial, is it, is it complex, and what areas might be occurring in. So it's a generalized idea of where, and not necessarily pinpoint. There's more advances that we've done that can even get more specific than what this is. There is Professor Inman. She said I could still use her picture. She has had an EEG. She had one at home and shared this one. It was a really long process to get all those leads put on her head. She said it took them 8 hours. It doesn't normally take that long. I think they just, whoever struggled that day with it, and it wasn't working right. So, but she said it was a really long process. She's good now. It was just a monitoring for some changes. A difficult process with agreement and getting people to do that. Like, think about 8 hours just to get this on. And usually we would do this in the hospital. Now this was outpatient. So there's some compromise we've done over time and developed our equipment where they can take the monitor with them and be ambulatory or at least around their house rather than being in the hospital for a week. Sometimes it's just an overnight EEG if they're really not concerned, or if they think it was something that's triggered by sleep deprivation or insomnia, they might make you stay up, be super sleep deprived, and then come in and then sleep and be evaluated. So like kind of like a sleep study, but with an EEG, and they can monitor what your brain's doing while you're sleeping, or even just before you go to sleep to see if they can trigger a seizure. So oftentimes we're gonna hold medications. If they've been on medications, we're seeing a change in their seizures or maybe an increase in frequency, they're gonna hold those medications to kind of trigger to see what kind of changes may be occurring in their brain and compare it to a previous EEG, because they've already been pre-diagnosed. So there's all different ways that we can use the EEG to help us either determine an initial diagnosis or what kind of changes may be occurring for a patient. This is like the lie detector test kind of thing, not to say that psychogenic seizures are people lying. You can have an actual psychosis that throws somebody into a pseudogenic type seizure state. But if we have them hooked up to an EEG, they can see, is it actual electrical misfiring or is it something psychological occurring? So that the EEG can kind of rule that out as well. All right, then there's some labs. Why would we want labs? What type of seizure maybe this would point to? Yes, which would be a provoking type seizure, right? So any of these metabolic changes or fluid electrolyte imbalances that may trigger a provoked type seizure. Maybe there's something underlying we can fix to stop these seizures, right? CBC for any kind of immune deficiencies or inflammatory processes going on, serum chemistry, kidney function, liver function, right? Urinalysis, glucose, ketones, those kind of things. All right, ruling out metabolic and electrolyte analysis. Okay, so I think that's my trigger for, medications. So I've got 4 different drug categories and then a couple of meds that are just kind of not categorized, but just common meds to talk about. So drug classes, we've got barbiturates, we've got hydantoins, we've got benzodiazepines, and valproates. So a lot of the medications that are still out there have been out there a really, really long time. This isn't for you to memorize and study for a test, but just to show like some of the first, like phenobarbital, back in like 1912, we still use that medication. It's just been around a long time. And we've got Dilantin in here, we've got a few others. And then by like mid-century, those are our first generation. And then as of the 90s and today and beyond, we still have some others. There's a whole bunch. So a lot for you guys to learn, right? So really it's more about the drug classes and the action and the common ones that we see prescribed on a day-to-day basis. So you may see some outliers, out there in practice or in clinical. If it's a medication you're not familiar with, you look it up and you realize, oh, it's an anti-seizure type medication. How is it working? Or how is this patient's disease process affecting them? This treats this type of seizure or that type of seizure. So you can have a better understanding of the med that way. But we're going to talk about some of the more common ones, the ones that just are good old standbys that we keep using because they work. So the goal of medications is to prevent seizures, obviously with as minimal side effects as possible. For our seizure disorders or epilepsy, cure is not technically possible, although there's advancements being done, some surgical treatment, some, again, for provoked type seizures, we could cure them if we fix the underlying cause, but we're talking about seizure disorders. There's permanent damage, they're gonna live with these seizures, they're gonna be on these meds their whole life. So that's what we're talking about here. 70% of patients respond well to medications for a little bit, and then maybe some tolerance occurs on certain types of medications and we have to do some adjustment. So a lot of our older medications, we have to do lab draws to check their blood levels for therapeutic effect and see if we need to do any adjustments. So these are things we're constantly revisiting, just like with your cardiac medications, your blood pressure medications. We're always revisiting their meds, especially if they've been on medications and now we're starting to have some problems again. That should be a trigger that, hey, we need to go back and look through their meds, maybe get some lab work done and see if we need to reevaluate this with their provider. So basically all of them are gonna be a CNS depressant. If you were to put them all in one drug category, that's the big category, CNS depressants. Going back to the pathophysiology, we're talking about excitability, overfiring of neurons, right? So we want to slow that down. We're gonna look at CNS depressants to slow down that activity and stop that misfiring. So for our seizure disorders, once it's diagnosed, we're gonna go right to medications. Again, it's not necessarily curable unless it's a provoked type seizure, but we're gonna wanna put these folks on medication. Some of these newer medications, it says here, don't require a therapeutic range. You'll see if it shows a therapeutic range, that means we need to check the drug levels. So as we go through these drug classes, we're talking about barbiturates here. We're gonna have a therapeutic range that we need for them, so know that we'll need to check their drug levels if it's outside of their normal range. Or we need to adjust their dosages if it's outside. So if the therapeutic range, I'm just jumping right to the train of thought here, was like a 10 for phenobarbital, that means we need to do what to their dose? Increase, right? Yeah, because it's not therapeutic, so we're gonna see more seizures, we need to up their dose, right? Okay, so backing up. Phenobarbital is a barbiturate, so I've underlined some memory joggers here for you. Phenobarb and barbiturates. Funny story, when I was in the Air Force, I was deep south Mississippi, Biloxi, and we had a family, like her son has cerebral palsy, and she would drive from Alabama to Biloxi, Mississippi because of the insurance with the military and all that stuff, and just to get treatment there when he needed hospitalization. It was, I forget how old he was, super little. Cerebral palsy, non-verbal, comes through the ER, and they ask, of course, the list of medications, and she's got this deep Alabama accent, and she's listing all the meds, and she couldn't remember this one. And she told the ER nurse, that peanut butter ball stuff. That's the story, I did tell you the peanut butter ball, whatever, peanut butter ball stuff. So she probably calls up with her kid, hey, here's your peanut butter ball. So I'm getting a report, this is my friend, the nurse in the ER. I'm getting a report, and she's going over the meds, and it took them a long time to figure out what that was. And she's like, phenobarbital. It's like, it sounds just like it. Fun story. So, of course, every time I see phenobarbital, I'm thinking peanut butter ball. So there you go. There's my story to help you remember that. It's a barbiturate, right? For tonic-clonic focal seizures and status epilepticus. Remember that slide? This is not as fast acting, but it's usually gonna follow one of our rescue medications. We might give them some phenobarbital. This is stimulating the GABA receptors. Remember? That's the inhibitory neurotransmitter that's gonna slow down that electrical impulse. So it's gonna hopefully stop that seizure. The inhibitory neurotransmitters. So if they don't have enough of their own GABA, this will open up those receptors so that electrical impulse won't carry through. So side effects, of course, CNS depressants, they're all gonna have some kind of drowsiness, maybe a little ataxia in particular with this one, discoordination. That can have speech, uncoordinated anything, uncoordinated gait, speech, action, thought. Respiratory depression and hypotension. So again, CNS depressants, slowing everything down. We're just gonna watch out, make sure they're not swinging too far the other direction, okay? Barbiturates, peanut butter ball. Hydantoins, phenytoin, dilantin, right? Toins, tonic-clonic, focal-like seizures, and others. A lot of these older ones that kind of are like, they'll cover a lot of different kinds of seizures, which is why we just keep sticking with them, because patients' seizure types can change and evolve over time too. So they just give them a broad spectrum type anti-seizure medication. So that's what we're talking about here. It slows the synaptic transmission at the sodium channel. Okay, so it slows down that impulse. Right? So in particular, this gingival hyperplasia, which I know our dental hygienist in the back room knows what that is. That's pretty common stuff. They've been on Dilantin for a long time, or phenytoin, sorry, I use brand names still sometimes. They are gonna have that, so what do you think a hyperplasia is? Is it? And not so much plaque buildup, but a hyper means bigger. Plasia, inflammation, yes, so redness, inflammation at the gingiva. So they get these big gums, and these are all side effects of their medications. It's just over chronic use of these medications, they'll have that. So if we've got issues going on here at the gingival area, the gums, what kind of nursing interventions are gonna go along with that? Say again? Hair, what, no? Soft toothbrush, yes. Good mouth care, right? Because it's redness and irritated and inflamed, so there could bleed, you can have infection. Anytime you have bleeding in the mouth and risk for infection, you've got cardiac involvement that you're worried about. So good mouth care, prevent infection, all right? So Dilantin, long-term use of phenytoin, sorry. Hirsutism, especially in younger, do you know what that is? It's like extra hair growth, like that fine hair, they get real furry. I know, sorry, furry, that's a recent term. My daughter knows about that. That's a middle school term now. So, yes, so hirsutism is extra hair growth, right? These meds have these weird things, like Dilantin's gonna kind of make some facial changes, right? Bone marrow suppression, so we're gonna monitor labs, right? That's where the CBC involvement comes in. Stevens-Johnson syndrome, a lot of these have that. I just wanted to bring that up there. So if you're noticing rashes on people, especially painful blistery rashes, this is a big deal. It's one of your like life-threatening type complications. You guys have seen this before. Every time you copy and paste in your center, your meds. What's the Stevens-Johnson's again? This is one of those, she doesn't know what I'm talking about. Seriously though, like, understand what these are, because if you see the strange rash and you're wondering where it's coming from, and the patient's in a whole lot of pain, it's blistering, it's a big deal. It can be life-threatening. Therapeutic range, 10 to 20. There's that 10 to 20 again. You'll see that a lot, right? The timing of your seizures, your therapeutic drug ranges. Oh, look, benzodiazepine, same thing, 10 to 20. So your PAMs and your LAMs. Diazepam, lorazepam. Tonic-clonic focal seizures, absence, again, broad spectrum, covering all kinds of areas. It's different types of seizures. Fast-acting, so these are some of your rescue meds when you're talking about status epilepticus. Very drowsy. Again, we're kind of seeing repeats here. These are CNS depressants. No big surprise there. But liver impairment, so that means it's metabolized through the liver, right? So if we're on these meds a long time, we're tasking their liver, so they've already got liver issues, we're gonna have some concerns here. And benzodiazepines are very habit-forming too, so there's tolerance and dependence too that comes with these. We do have a reversal agent, so if we have overdose and we see too much CNS depressant or CNS effects, respiratory status, heart rates drop too low, we've got too many benzos on board. We're gonna go ahead and give some flumazenil, of course, by order. But we do have a reversal agent for this one. Valproates, that's that fourth drug group that I've got listed there. Common valproic acid, Depakote. This one comes in these sprinkles in a capsule that we can open up, especially in pediatrics, and sprinkle on their food or applesauce. All types of seizures, still give these a lot. Liver impairment, bone marrow, GI issues, similar side effects as the others as well. We have a different therapeutic range here, 50 to 100 micrograms per milliliter. So when we draw their drug levels, we want it to be in between 50 and 100. You guys understand that, right? To be within therapeutic range. That's on the drug level side. I'm not talking about like therapeutic in the dosing side. We're talking about drug level in their blood. So serum labs, green top. Spun out, look at the serum, how much drug is in it. 60, we're good to go. go on and watch it because it's on the lower side, right? Good? Now I have a hard time with this one. Levetiracetam, just Keppra. You just call it Keppra. It's levetiracetam, I think. Am I saying that right? Tiracetam.
I guess never say it right.
I used to say levetiracetam, but it's wrong. It's not. Keppra. Keppra. Red liquid, real sticky. Spits out a lot because it tastes bad. So I give it to kids. They don't like it. It's much better in the tube. Just kidding. Yeah, some of them have the tube, but there's a lot of medications with people with seizure disorder. So you come in with like a whole bunch. You gotta keep track, put labels on your syringes. But this one, there's a max daily dose. Going back to your dosage calc here, how much they get in a 24-hour period. 3 grams per day. That's adult max dose. It's probably a mg per kg for pediatric. This isn't for memorizing, just kind of like there's a daily starting dose, and this kind of applies to any of the medications. There's usually a starting dose, and we will start them on that lower threshold and advance them as their therapeutic levels fall within range, right? So we'll follow those and check their lab work after a while. Obviously monitor their seizures, see if we reduce the occurrence or eliminated seizures. So some of them can cause the bone marrow suppression, so we're looking, for anemias and bleeding disorders, so blood dyscrasias are things we're going to be concerned with. Pancreatitis. Bone loss has to do with that calcium. So how it works on these calcium channels, right? So we're playing around with where calcium is, so we can cause bone loss. This is of course like long-term chronic use side effects. They're at a toxic level. If we have too much drug, so if we're on the other side of their dosing here, we've got nystagmus. You guys know what that is? Yes, the eyes back and forth, right? Kind of like they were spinning, right? You spin somebody around, you stop them, and then their eyes go like this, right? That's kind of what it looks like. Decreased coordination, decreased cognitive function, decreased alertness, right? Those are signs that they have too much in their system. Obviously, we want to catch that before it gets to, increase in seizures, coma, or death. Carbamazepine, aka Tegretol. This is a medication, not a drug class, but these are the extra twos that kind of are still in anticonvulsants, but not falling under the other categories. These are newer medications, but we see these a lot. So this is one that I think NCLEX likes to ask questions because there's certain medications that don't do well in an acidic environment. This is one of those, so we don't want who takes anything with grapefruit juice, who drinks grapefruit juice, unless you're 85. But acidic, so orange juice or anything like that. I'm sorry, somebody here really likes grapefruit juice and I just offended you. I'm sorry. Side effects, leukopenia. Again, so similar things, we're seeing more of this stuff again. Stevens-Johnson's syndrome in this one. And that one begins with those flu-like symptoms and then they develop that rash. So there's a drug level here, 4 to 12. Okay, and I think that was the last that I listed for you. So a little bit of a review. Understanding their action. So overall, with all of these CNS depressant type medications, what we're trying to do is change how the electrical activity is occurring in their brain, either through these ion channels that they axon, right? Whether we're opening up one channel and closing another, but to slow down that electrical conduction in the nerve cell, or altering chemical transmission of those neurotransmitters. So we're either working at the gate, where the receptors are, or we're working on the neurotransmitter that's secreted to begin with, right? Did I lose you? You got it? You hit it. Glutamate and GABA. Glutamate is the neurotransmitter that does what? Excites, right? GABA does what? Inhibits. Inhibitory neurotransmitter. Say the beginning part there. and how they work? It doesn't say that. So yeah, well, I was pulling in the takeaways in those particular pieces. What's important to know is that the drug group is going to have a certain type of action on whether they're working at the neurotransmitter or that they're doing a sodium channel. Really, it's not as important on the action in that sense. I don't want to say it's not important because they're going to do one of three. They're going to be on more than one medication. What you really want to know is like more like how do I then take care of a patient who's on that medication, and knowing that that's what's the goal of this medication is to cause a slow down that CNS depressant. So I want to know about like safety on these medications or certain like I don't want to give them grapefruit juice, right, to take the medication, or a lot of these like here's these other cautions. This is another piece here that I want you all to focus on. That triad of toxicity, when we've swung the pendulum too far the other direction. Knowing that these are CNS depressants, I want to be looking out for signs that show that I've depressed them too far, right? Respiratory status is decreased, their heart rate's decreased, right? Lack of coordination. I know some of these look like signs of seizures, but this is during their treatment and a change from their baseline, right? So once we've gone into toxic levels here. So because of that, like we want to do a slow wean off of these medications. We don't want to abruptly withdraw them off of it because that can trigger some seizures. And pretty much all of them are in a pregnancy risk category. So if you have somebody who is family planning and they want to become pregnant, then they have to determine if their seizures are severe enough that they need to stay on medication and put risk for birth defects for their child. So that's a tough one for some people. And a lot of people do stay on their medications because their seizures are severe enough. And depending on, they might switch a medication to one that has a little less risk than others, but they may stimulate a new type of seizure for that person, or they may increase frequency. So they might just lower the dose to a threshold where it's not as risky for the child. Right, because we don't want to go into epilepticus, then we lose both, right? Mom and baby. So only given if risk outweighs the benefit in that case. Do we need another quick break? I think we're pretty close. No, just keep going? Keep going, okay. There's only a few on these. Medications was kind of a big one, not as big as diabetes, but I wanted to go through the drug classes there so you know what medications and what precautions we're looking at here. Okay, so medication, as I said earlier, was their first choice for someone with a seizure disorder. Obviously, if somebody has a provoked seizure, we're gonna treat the underlying cause, and that should take care of the seizures. But your unprovoked seizures, your seizure disorder, your epilepsy, medications is our first choice for treatment. Because despite the side effects, it's still a better option. We don't want to go in and start messing around in someone's brain with a knife, unless we think that can fix things and cure them. Or if they have a tumor, again, a provoked piece would be like a tumor or something that we can go in and remove and solve both problems. Potentially, there are tumors that are in places that are inoperable. We would cause too much damage to get there. So, surgery is often an option for many with uncontrolled epilepsy. They might be able to pinpoint exactly where that damage is, where those seizures are occurring, and remove that portion of the brain. So with this type of surgery, 80% are usually seizure-free 5 years after the procedure. And some start to have new seizures, but it's still pretty high success rate after 10 years. 72% are still seizure-free. I think this is my only slide on surgery. Yeah, let me back up a little bit. So this is some cool advancements that are going on here with surgeries, because it's been too risky to go in there because you can risking taking a lot of healthy brain tissue. Now they can do this mapping. They do it over here at Children's. They can open up and go in. It's different stages of surgery. So more than one visit to the OR. First visit, they open up the brain and they can put EKG or EEG electrodes directly on the brain, cover them back up, and do inpatient monitoring and really pinpointing where the source of that misfiring is occurring through that mapping. It's insane. It's like super sterile, but they've got the electrodes that come out of their skin, they've got a dressing on their brain, on their head, and those EEG electrodes, but it's, instead of over their skull and on their skin, it's underneath and directly on their brain tissue. Crazy what we can do now. Yes, they do it a lot in like Houston and some other bigger hospitals. They do it here at OU too. My friend went to Houston, but that's just because his doctor was over there. But that's been done. They can get even more pinpoint in the surgery and know exactly where to go by doing that. So just a fun fact. So vagal nerve stimulator. My friend Jonathan has one of these. So medications, rescue medications, and sometimes a vagal nerve stimulator can help people. So what this is it looks like a little pacemaker. It's under the skin, usually on the left side of the chest. It's got a little wire that attaches with the vagus nerve to cause stimulation, because the vagal nerve will cause a inhibitory response in those neurotransmitters. It's a CNS depressant, basically. So it sends this electrical signal to the vagus nerve to slow down excitatory neurons, right? Parasympathetic response is what we're going for here. So some of them are set to give impulses like regularly every few seconds. That's depending on the surgeon and what they've decided to do for that patient. But there is a handheld device, a magnet that you can swipe over the device. Sometimes it's in the neck for some people, sometimes it's right on their chest. And they take that magnet when they feel that they're in a seizure and it's an alert, aware type seizure, and they can swipe that magnet over, or somebody else, the school nurse, can swipe that over to help them pull out of their seizure. So it'll stimulate that vagal nerve and stop that misfiring. So it's kind of like they've got a basal, and then this is for breakthrough seizures, where you need a little extra charge from your vagus nerve. It says battery replacement every 3 to 10 years. My friend had his replaced after a year, because it's going to need more frequent replacement, and this is surgery. They have to go in and replace the battery surgically. But the more it fires, the more it uses the battery. So sometimes people, if they're having more seizures and it doesn't seem like their magnet's working for them, it could be the battery. So his is actually, it looks like one of those fitness watches. It's just got a little magnet on the watch piece, and he can put it here and just kind of put it on this end and just swipe it across his chest if he needs a little vagal nerve stimulation. But some people have like a big device and they wave it over it. It's kind of like the wand at the airport. A little smaller than that, but really cool. Different things that we can do. So here's some of the mapping, kind of what I was talking about, but this one is specifically implanted the RNS, the responsive neurostimulation, so it can be mapped directly and placed, and then the little pieces on the external side, so they can adjust it as needed, but it continually monitors EEG to detect abnormalities and the response. So when it sees that abnormality, it can respond to deliver electrical stimulation to that location and kind of do like a reset. Kind of like a pacemaker for the brain. Cool, right? I was going to say, it's not brain surgery, but it is brain science. Neuroscience. Super complex. Okay, everybody's heard of the ketogenic diet, right? So we've had this for a long time. Not for weight loss, but for for seizure disorders, right? Epilepsy. So when medications aren't working, surgery is not an option. We're going to continue medications, but we're going to go ahead and do the super complex ketogenic diet, which never in my life has ever been anything anybody could do on their own without a dietitian. So all this bad diet stuff out there, the ketogenic, they're probably not doing it right, unless you're super weighing everything and super strict with it. But it's not really good for you to do as a weight loss diet. So I'll get off my soapbox on that one. I won't stay on it too long. But primarily in peds, when medication is not working, right? Let's try a ketogenic diet, because it's really harsh to be on this long term, really hard on your kidneys. So, and we really don't know what it does to people long term, but it's essentially high fat and a low carbohydrate diet. Kind of like Atkins, but not. Not Atkins. So the idea here is we're providing ketones as energy for the brain, right? Ketones pass to the brain and replace glucose as a source, as an energy source. So again, it's not going to work for everybody with the seizures, but it's something that if we're having difficulty with their medications, that we're gonna go ahead and try this ketogenic diet. So it does require a dietitian, really specific formula. This worked pretty well for the kid I was talking about in the medical daycare, who had a lot of tonic seizures. We had him on a ketogenic diet. He was tube fed primarily, so it's super easy to keep a rigid, strict ketogenic type diet. But it was really difficult on his equipment because it had a lot of fat, it would stain the tubing, and sometimes tubing would get clogged when we're trying to get his tube feeds. And so it can be a little difficult to work with, and it smelled horrible too. But that high fat, low carb type diet, but it was real specific, helped a little bit. But again, those are the key things. Requires a dietitian consult to get it right. We're talking about high fat here, and we're talking about how it can be harsh on their kidneys, right? So long term can be really tough on them, but it should provide relief until we can maybe figure out what to do with their medications, maybe look for surgical options, things like that. All right, so a few slides on nursing interventions. We're wrapping this up. So seizure precautions I briefly mentioned before. So here you are, you got report from the ER. Somebody's coming up that takes peanut butter ball routinely, and they have a history, right? I'm going to initiate seizure precautions. You don't have to wait for an order for that. You know this person has a history. We're going to put seizure precautions is going to be standard for them, right? We're going to assess and position the patient, right? Especially if they're during seizure. We'll talk a little bit, we got a couple slides with postictal care and privacy, so some considerations. So we're gonna be with them while they go through it, right? So we're gonna provide safety and privacy for them during and after that seizure. We have to consider documentation. So we go over all the different types of seizures so that you can document as best as you can with what you know and what you observed with what was going on. And that gives the provider, whoever's reading the chart, a better understanding of what's, what type of seizure they might be having, and is this a change from what their history states, right? Seizure medications that we'll be administering, these are another collaborative intervention. And then the patient teaching piece, what are the risks? What's the medication plan? What's the rescue plan? Do they have one? This is a kid in the school, they need to, there's documentation they have to provide the school so they know exactly what the process is, whether they're getting intranasal Valium, whether they have a magnet, is there an extra magnet for the office to have, so that all these things, workplace might need to have this person's plan so they know what to do in case they have a seizure at work, and that they can go to their rescue plan. So we need to communicate to them that they get that information to school or work, right? And then how to avoid triggers. When they've determined what triggers their seizures, how do they avoid them? And any other referrals, like to dietary, right? For a ketogenic diet, if they're on one. So here's a picture of your seizure precautions. So we have some nice fancy padding that we can put on the rails, or we just take the pillows and the silk tape and wrap it around, or the bath blankets, you've seen that too, just to kind of keep them from bumping into that hard plastic. People get bruised during seizures even regardless of the padding, but still it's better than hitting that plastic rail. So those are nice. They'll sit up in the bed and they'll really cushion them well. So we've got loose clothing. Why loose clothing? For strangulation, yes. So they're sliding around in the bed. We don't want it to occlude their airway or anything like that. What else do we have here? Oh, before they even get in the room, obviously you're going to set this up, but what's going in the back wall? We talked about this in lab. Yes. Why suction? Because they don't aspirate. Why? Because the extra saliva, that's probably going to, okay, so they might aspirate. So we have working suction. Every patient gets one. But you got a trach patient, you got a seizure patient. If you don't have that in there, you're going to be in trouble. You need to make sure that's in there. We got the privacy curtain. So if they're having a seizure, we're going to give them a little privacy while they go through it, right? Side rails are up. We see a third rail down because this patient can get up to go to the bathroom. We don't need to restrain them, but we just at least want to protect them so that they don't fall into the bed on the top. pillow to protect their head. What position are they in? Sideline. Why? Risk for aspiration. Now, I mean, this is like the patient that might need assistance with turning. We probably won't leave them supine. We'll just go from lateral to lateral, left to right. People can move and turn themselves in bed anyway, so you may walk in and you have to position them. So that's part of your response. That is in lowest position. A lot of these things are things we're already doing anyway, right? So we just make sure, because they do have that third rail down, so if they do wiggle their way out, we want to make sure they don't have as far to fall. Okay. Now, I didn't talk so much about the event itself. So in this picture, we got them sidelined, because what are your concerns during an active seizure, especially like your tonic-clonic type? Aspiration, airway, injury, yeah, safety. Tongue can roll back too, so that all of that could be risk for including their airway. So that's your biggest concern. You've got suction to keep that airway patent, right? So we make suction secretions, even though that they're on their side, it could cool off a little bit more too, right? They don't usually vomit during the seizure, but they could vomit afterward too. So suction's there for that, to help keep that airway open during that process. Have an emesis basin nearby, right? Because it just, especially if it was very physical, very motor type seizure, you could have a lot of like upset stomach and nausea afterward after all that activity. And that lactic acid that's probably released too, okay? So keep them on their side and keep their airway patent and that pillow to protect their head. Now this is a hospital environment. What about out in the community? Put them on their side. That is your first aid. Anybody ever take a first aid class? Put them on their side, protect their head. If it's on campus and they have a backpack, put the backpack under their head so they're not slamming it on the hard pavement outside, right? Or get them off the hard pavement if you can, pavement, and put them in the grass so they don't get burns. We've had that in the burn unit. Somebody had a seizure, passed out, and they were in the driveway in the middle of Oklahoma summer and got burned from the heat of their driveway. So they had the seizure to deal with, but they were on the burn unit. So, think of things like that. Get people to a safe spot, stay with them. What else are you doing during the seizure? Timing it. Yep. Know when it started, know when it stops. Just part of first aid, outside rescue. If you don't know them, you might be looking for jewelry. Is it a known seizure? Because this could be something that, they're aware that happens. They may not have jewelry and you don't know if it's a new seizure. It never hurts to call ambulance if you're concerned. You can call 911 to have somebody come. I know we don't normally talk about external response. We always talk about hospital type response, but you could witness one of these type things. So your priorities are the same externally with your airway and your safety. But whether you call somebody, you don't know their history necessarily, or whether this is something that's expected, or whether we need to be worried about status epilepticus and get an ambulance there. But just some things to think of if you ever have to respond to something like that. Okay, so that's your treatment during a seizure and your preparation for safety for before. And then this was a mnemonic that I got to help remember some of the triggers and what you can teach people for those like provoked type seizures that may cause like extra stress or trauma, or some of these things, overexertion. So stop seizure helps you kind of remember that. Hormonal changes. So again, some of these are provoked. Trauma could be more of the unprovoked, depends, or it could be the acute inflammation that can cause problems. Sleep loss, so that can be a trigger. That for sure is a trigger for a lot of people. If they're sleep deprived, they might experience some more seizures. So this goes for your epileptic patient. Electrolyte and metabolic issues, illness, visualization disturbances. So some of these are triggers and some of these are just like, well, what can cause, like even just like flashing lights and stuff, or what they might experience. So the video games, all those warnings in movies could trigger a seizure, so they need to watch for those things. Are they having their drug levels checked? Are they under-medicated too? Do we need to adjust their doses? Avoid recreational drugs, and E2H is alcohol, I don't know if you know No drugs and alcohol. All right. There are lots of resources. These are things that are great for you and for your patients. Just sharing, the Epilepsy Foundation has lots of videos too. There's plenty of videos online. And in looking for videos to show you, I found like this group in Toronto that has a lot of videos, and they're all acting videos. So they're not actual seizures, but so just keep in mind, there's the educational videos out there that are people acting out a seizure and not the actual thing. But if you're curious to see the different types, they're pretty good actors. So lots of stuff for your studying. I think what we're gonna do is let's take these next 10 minutes, take a break,